everyone. My name is Agnieszka Strzembosz, and on behalf of Medtronic, I would like to welcome all of those who would love to spend this hour with us. We have an outstanding masters who are going to discuss clinically relevant phenotypes in CRS. I would like to welcome Professor Claire Hopkins from London, Professor Richard Harvey from Sydney, and Professor Raymond Sachs. So Ray, would you be so kind to start this fascinating discussion by introducing our fantastic speakers?
First speaker is Professor Claire Hopkins, who's Professor of Rhinology at King's College in London. She's a consultant ENT surgeon at Guy's and St Thomas's in London. She's also about to become the president of the British Rhinological Society and is currently the president-elect, and she's treasurer of the European Rhinology Society. She also is the founding chair of Women ENT, and she has the most ridiculous curriculum vitae, which would take me the next 4 hours to even vaguely summarize. She really is a huge asset to this webinar, and she's got so much to contribute to international rhinology. So I'm not going to waste any more time, and I'm going to welcome Claire to kick off.
Hello, I'm Professor Claire Hopkins. Thank you very much for the invitation to speak tonight. I'm going to talk a little bit about implementing precision medicine in rhinology and where better endotyping or subgrouping of our patients will contribute to delivering precision medicine in the future. So precision medicine really is an aspiration for the future. And the idea is that if we better understand how an individual's genetics, environment, lifestyle, and disease characteristics all contribute to their underlying disease, we can better determine how to approach both disease prevention, which is obviously the goal, but also better disease management. There are 4 key principles in precision medicine. It should be predictive. We should be able to identify those at risk of disease. It should be preventative. We should try and find ways to prevent those at risk from developing clinically active disease. It should be personalised, and this is where endotyping will really come into its own. It should be participatory. Patients should be empowered to be active and manage their own condition. Now, in the future, I imagine that patients will come to our clinics, they'll have a blood test taken, perhaps a blood spot, perhaps a mucus sample taken by a wire brush. We'll feed this into a computer, and it will give us a printout telling us exactly what type of CRS the patient's suffering from and how we might best treat it. I suspect in the future that treating CRS with antibiotics and with very non-selective steroids will really become a thing of the past, and instead we'll have very tailored medicines such as specific biologics that will address them. Perhaps even in the future surgery for sinus disease will become a thing of the past. But this is all some way off. And the problem with all of this is that all of these tests cost a lot of money. And certainly in the NHS where I work, we've run out of money, and we're trying to deliver better quality care, but increasingly on smaller and more restricted budgets. So I'm going to rename my talk How We Can Implement Precision Medicine in Rhinology, but on the cheap, in as cost-effective manner as possible. So starting with predictive, can we identify which patients are at risk of developing chronic rhinosinusitis? Well, we don't know much about risk factors, but we do know that we have certain populations who are at higher risk. For example, patients with asthma, aspirin-sensitive respiratory disease, those with cystic fibrosis. And these would be good patients that we might employ screening programs. These patients often have undiagnosed upper respiratory disease, which contributes to their overall morbidity. So if we just encourage our colleagues in respiratory clinics, for example, to ask a very simple question about a patient's sense of smell, we might pick up a lot of these patients. And actually, anosmia has an 80% positive predictive value for finding nasal polyps. So this might be a good start and very cheap to deliver. We know that anomalies associated with a bitter taste receptor are also predictive of a higher susceptibility to CRS, and that non-tasters have higher rates of bacterial colonization. So perhaps you might screen patients in the community for whether they can taste PTC, a very simple and cheap test to identify those at risk. One of the problems with this approach at the moment, however, is although we might achieve early identification, we haven't yet found ways to modify the development of disease and actually prevent it from happening. There are some things that we know are associated with a much higher risk, both in terms of developing disease, but also greater disease severity. And perhaps the most important and most widespread is smoking. About 40% of European adults continue to smoke with similar rates, albeit slightly lower in the United States. And this is a key area that we need to focus on our efforts. We know that smoking is associated with a higher risk of developing chronic rhinosinusitis, and it's dose dependent, so there's a 1.5% increase in risk for every additional year of smoking. The Galen study showed that nearly double the risk of developing chronic rhinosinusitis in smokers compared to non-smokers. Passive smoking also increases the risk of developing chronic rhinosinusitis in adult life if you're exposed to cigarette smoke in childhood. We also know that patients who develop chronic rhinosinusitis have poorer outcomes from medical treatment and most importantly from surgery if they continue to smoke. So again, this is another area that we can target to try and improve outcomes for our patients. So we really need to think about smoking cessation at every clinical visit and try and counsel our patients. We need to get them to actively engage in services to try and help them quit. What about other things that might be involved at higher risk? Now, this is a really interesting slide that looks at the development of chronic rhinosinusitis in the first responders to the 9/11 World Trade Center disaster. And the first responders were exposed to very high levels of dust, toxic chemicals, and all kinds of awful things. And they've gone on to develop very high rates of chronic disease. But what's very interesting is that they also developed very high rates of chronic rhinosinusitis, up to 50% in some groups. And if you look at how much exposure these first responders had, you can classify them into three groups. Those that attended very early on in the first 4 hours of the towers coming down, those that were in the second wave between 4 and 12 hours, and those that came in later. And so those that arrived first at the towers had the very highest level of exposure to dust and irritants. And you can see that they have much higher rates of developing CRS, up to 50%, compared to those with lower levels of irritant exposure. This was a single point in time of exposure, but it's affected their risk of developing chronic rhinosinusitis in the 10 years afterwards. And I think this is the first really convincing evidence that I've seen that occupational exposure can make a real difference to the risk of developing chronic rhinosinusitis. Again, we're quite limited in what we can do, but it's certainly something we should be asking our patients about: the air quality in the place of work and pollution levels, for example. And as much as we have the power to, we should lobby governments to try and reduce exposure to irritants, put in safety measures, and try and improve air quality in general. Now, the next key tenet of precision medicine is that it should be personalised. And that's exactly where chronic rhinosinusitis is a problem. We have this huge mixed bag of conditions that we put together under one subheading. We might have patients with polyps. We might have some with allergic fungal disease. We might have patients that have a simple dental infection mixed in with those with secondary CRS and high levels of bacterial colonisation. And we put them under all one umbrella at the moment and try and find a one-size-fits-all approach to treatment. And obviously that's not going to work. What we want to better do is to sort our patients into groups so we can have homogenous disease groups that will have a predictable response to different types of treatment. And that really is the key feature of personalised medicine. Now, at the moment, we have two main groups, and we use these in guidelines such as the EPOS guideline, which is available from rhinologyjournal.com. We have two main groups, patients with polyps and those without. And largely, we know that they differ in their response to different types of treatment. So here, for example, we can see the algorithm for patients with polyps. This is a predominantly inflammatory condition, so the mainstay of treatment is to use topical steroids, be it in the forms of sprays or drops, or oral steroids when the problem is more severe. There's very little role for antibiotics in this group, although there may be some use in doxycycline, possibly as an immunomodulator. But again, if this approach doesn't work, we'll consider surgery in our patients. In contrast, the group of patients without nasal polyps, we would again treat with intranasal corticosteroids and saline. In this group, we'd also be considering the use of sometimes low-dose macrolide antibiotics. So this is more, again, of an immunomodulatory drug. But we know that the patients in this group are more likely to respond to macrolide, particularly if their IgE is not elevated. So again, already in this pathway, we're seeing different biomarkers being used to try and help predict response to treatment. But again, the problem with this is this simple classification into patients with polyps and those without isn't a clear dichotomy. They're not two obviously very distinct groups. And there's certainly some overlap in the middle. For example, what about the patients who have polyps in their CT scans but aren't visible on an endoscopy? Where do you put those? And a bigger problem with this classification is it also depends on how well you can look into the nose. So, for example, if you're in primary care and you only have access to rhinoscopy, you're going to be much less likely to see small nasal polyps than if you have an endoscope in the clinic. So it's perhaps also more limiting for primary care doctors. There is a significant overlap in the middle, and we know that about 20% of patients with chronic rhinosinusitis without nasal polyps actually exhibit the immune profile of patients with polyps. They just simply haven't developed their polyps yet. So we want to try and better classify these patients so we can more accurately split them into their different groups and better treat them. As I said, it relies on their endoscopic appearances. It doesn't consider what's going on within the sinuses unless there's been previous surgery. And we know that at least 20% of those without polyps exhibit this Th2 type profile. Endotypes, in contrast, use biomarkers or biological tests to better guide treatment and prognosis. Now, we've known for some time that there are two large groups, patients that exhibit a Th2 type inflammatory response, where they have high levels of IL-4, IL-5, IL-13, they might show raised IgE, and they're characterized by eosinophilia. And this is typically, but not completely, associated with the group of patients that have nasal polyps. We also have a group of patients with a Th1 type response, with interferon gamma, increased matrix metalloproteinase, neutrophilia and fibrosis. And this, again, not exclusively, but more commonly is associated with those patients without nasal polyps. We're learning about other groups too, Th17, for example. I'm sure this list is going to expand significantly over time. Class group in Ghent has done some excellent work in this area, and they've identified at least 10 different types of endotype clusters based on levels, for example, of IL-5 and Staph aureus superantigens. And you can see from the graph on the right that some of these different clusters are associated almost exclusively, but again not completely, with the polyp phenotype, whereas at the top end it's much more a group without polyps. It's also related to the risk of asthma. So we're starting to hone in on that mixed bag of sweets at the beginning and try and much better define our group of patients. But this involves, to identify the bottom group, for example, testing at least 6 or 7 different cytokines, be that in mucus, in histology, or in blood tests. And again, that all adds to the cost of managing what is a very common condition. Chronic rhinosinusitis affects 10% of the population. So it's perhaps not realistic to take this level of detail in all our patients. Is there a way, therefore, based on some simple questions and what we can see, that we can approach this and to some extent? So this is how I approach patients in my clinic. And as you can see from the slide, I take an approach of trying to endotype for free, so without any additional tests. First of all, I want to establish that the patient has chronic rhinosinusitis. So I'll apply the EPOS definition of at least 2 symptoms, one of which should be nasal obstruction or nasal discharge, and or facial pain and pressure, and all symptoms of mouth. And using that, I can establish that the patient's had chronic rhinosinusitis if their symptoms have persisted for at least 3 months. I'll then look in the nose with an endoscope and see if I can see any visible nasal polyps or not. If I can see nasal polyps, then it's likely that the patient has type 2 inflammation, and I'll treat them according to the EPOS algorithm for nasal polyps. But there's another important subgroup within this that has been really well described by Richard and Ray involved in the call tonight, and also John Delgadio and Sarah Wise's group in the States. And this group has what we now term central allergic compartment disease. They have a significant allergic drive to their underlying inflammation and sinusitis. They might have polyps coming off the middle shoulder, disease focused particularly in the ethmoid, and relative sparing of the frontal sinuses and the maxillary sinuses on CT images. They might not even have frank polyps, but just have simple edema of the head of the middle turbinate. And having read the papers published from Rich and Ray, I found this a really useful sign to look out for in my clinical practice. And it will really drive me to focus on the patient's allergies and management of those to try and optimise their outcomes. I then consider patients who don't have any visible polyps, and I ask them about any personal or family history of asthma or allergies. Those that had asthma in childhood, again, more likely to fall into the group with Th2 type inflammation. have no history of asthma or allergies are likely to be TH type 1, and I'll treat those very much as a non-polyp patient and follow the appropriate algorithm. When you have patients with adult onset asthma, and they're a slightly more complicated group. Those who are older smoking males and obese females are most likely to fall into the TH1 group. But the rest of patients who are overweight and non-smokers are likely to have TH2 inflammation. And again, I'll treat these patients as a polyp patient. There are some clear differences between the two algorithms. For example, in patients without polyps, there is no recommendation to use oral steroids at all, partly because there's no evidence upon which to really guide that decision. But if they have adult onset asthma or other features, then I might consider the use of steroids in patients, even if I don't see frank polyps in the nose. And when I come to surgery, I will try and achieve more open access to the sinus cavities to improve access to topical steroids post-operatively. So I think just asking a few simple questions in the clinic can really better help us to define our patient population, particularly when we can't see frank polyps, but the patients have features, is that they may better belong to that group. Final part of precision medicine is that it should be participatory. And certainly the most cost-effective healthcare is self-management. It's ideally suited to chronic relapsing conditions such as chronic rhinosinusitis. And it's really important because actually we know that compliance is really poor in patients with chronic rhinosinusitis. There was a nice study done by Luke Rudnick's group in Canada, and they found that only 20% of patients with chronic rhinosinusitis are currently using an intranasal corticosteroid. Now that might be a little bit of underprescribing, and it might simply be that the patients haven't bothered to collect their prescription. Even those that use it, they often fail to use it regularly, so they collect on average 2 bottles of spray a year, when it should only really last a month or 6 weeks, so they're perhaps even only using about 20% of the amount that they're prescribed. So we need ways to try and improve patient compliance, and that must be by actively engaging them in their care. So we've been working on some different approaches, for example, using a smartphone app. This is My Sinusitis Code, and it encourages patients to enter their symptom levels on a visual analog scale on a daily basis, and it will remind patients if their compliance isn't as good as it used to be. So it will really encourage patients to use their sprays regularly, to consider when they need to go back and see their primary care doctor or their ENT doctor. And it just gives them more information as to how they're doing overall and when they're starting to fall off track a little bit. It's also been shown that using things such as this chronic sinusitis action plan and to give patients written information after consultations can really help engage patients and improve compliance. So this has come from a group in East Canada with Martin de Rosier, where patients are given a clear plan. They're told what type of sinus disease they have. You can see it at the top, I have with or without nasal polyps. And it will guide them as to what treatment they should be using on a daily basis, what to expect when they're getting worse, so when their control is starting to fail and what they should do. And it also clearly signposts when they need to seek immediate help from either the emergency room or their ENT doctor. So again, sending patients away with this, with better instruction, can help improve their management. So in summary, precision medicine is likely to achieve improved outcomes for our patients with chronic rhinosinusitis. Better subgrouping of patients is absolutely central to implementing personalised precision medicine. Hopefully I've shown that a few simple questions in clinic may improve our ability to better subgroup our patients and therefore better identify how to treat them. And certainly this endotyping will become much more important in the future when we have better biomarkers to guide best management for our patients. Thank you very much for your attention.
Thanks very much, Claire. That was a beautiful presentation. And we're going to talk a little bit more about it later during the Q&A. I'm going to go straight on and introduce Richard Harvey. Richard, as most of you all know, is Professor of Rhinology and Anterior Skull Surgery at both Macquarie University and at University of New South Wales. And he runs the Rhinology Research Group at the Garvan and has published in excess of about 200 publications and has written multiple books. Richard is a true international leader in the field of endotypes, and it's going to be our privilege to hear him talk. So, Rich, I hand over to you, sir.
Thank you very much for joining us today. This is an exciting topic that I want to talk about because I'm going to discuss, as a rhinologist at a tertiary level, what we do in our practice to really separate out the different types of sinus disease and how we manage them. Now, we all acknowledge that there are patients who come and see us who have very discrete focal anatomical problems in their sinuses. Now, these patients here are examples of people who have a discrete problem in one sinus. They don't really have evidence of broader airway inflammation. The problems here that exist in these patients are anatomically discrete. They're relatively straightforward to sort out. And this is where endoscopic surgery certainly is an enormous value intervention in improving these conditions. But I would portend that this is not the typical patient that comes and visits an otolaryngologist. This is not who we see in day-to-day practice. They are great examples of anatomically or focally discrete problems, but this is the sort of patient that is typically seen in the community, someone who's developed patchy and diffuse sinus changes. And this patient doesn't have an anatomical problem or a discrete issue. They've developed an inflammatory response across their airway. This is not a patient with simple osteal occlusions. They are simply a patient who has an inflammatory reaction. Now, it's very important for me as a surgeon and as a rhinologist that I match up what I'm trying to achieve surgically with the condition. Now, we do have these great examples of anatomically discrete problems in the sinuses in which there is just simply a plumbing or obstructive or ventilatory pathophysiology. And in those patients, simple sinus surgery, in some of those tenets of how sinus surgery came about, it is a terrific solution. But at this end of the spectrum, where it's more about inflammation, what we do as surgeons cannot be the same foundation and principles as what's on the left-hand side of the spectrum. It is this group of patients in which we apply a very different type of surgery, one that's simply designed to create a simple cavity or near sinus cavity for the purposes of managing what we acknowledge is an inflammatory disorder. And so there is no point in my mind doing a ventilatory disorder for a condition that we know is inflammation, and we don't necessarily have to open up all the sinuses in someone who has an anatomically discrete problem. The condition and surgery must be in harmony is what we're trying to achieve. Now, this is very important because when we see surgery applied where it's not in harmony with what is going on as a pathophysiology in the patient, it becomes a problem. So if we fail to acknowledge that ventilation and plumbing is not really the cause of sinus disease, then you're going to lead to failure when it comes to managing sinus disease. But if we acknowledge that sinus disease really constitutes a group of conditions in which inflammation and mucostasis, which is usually a secondary event, a major pathologic process, not just simply blockage and ventilation, and we use surgery to break this process, this is when we'll have success. And on this side, it's really where our clinical practice is not in harmony with what we understand to be true from our knowledge of sinus disease. And on this side, this is where our understanding of sinus disease and what we're doing clinically are much more aligned. So let's talk about upper airway inflammation. This talk is about that diffuse inflammatory process, this patient here who we're talking about. Now, how do we predict what sort of inflammation is going on in these sinuses? We might look at the turbulence, look how congested the nose is. We might look at what sort of mucin's coming out. Maybe they've got polyps, no polyps. But we can actually be more scientific about it. My colleagues in Europe, Thibaut van Ziel, Galen Group, they've tried to endotype different sinus diseases, and they can clearly demonstrate that there's very distinct groups. However, the sort of biomarkers and testing here are not available to a practicing clinician. Now, what I think is important is that we acknowledge this. We sadly are behind respiratory physicians when it comes to airway inflammatory research. And I think understanding that respiratory physicians have been there and already been doing research in airway inflammation for many, many years is very important. And one of those people is Sally Wenzel. Many years ago, 6 years ago now, that she wrote this article about asthma phenotypes, I think is very poignant because this is about where we are at in our understanding of upper airway disease. Now, this graph shouldn't be intimidating. It just talks about severity on the vertical axis, and on the horizontal axis, we have the age of onset. And down below, at the young age, we have those allergic conditions, classically IgE-mediated disease. In middle age, in the severe end, we have the eosinophilic disease patients. And then in the adults, we have a group of patients who are less eosinophilic and less corticosteroid responsive as another phenotype. So I'm going to use Sally's diagram here to tell you where we're at when it comes to management of the upper airway. Now, the first group is that of childhood and young adult asthma. These are people who get rhinitis, asthma. Doctor, I've had sinus disease all my life. What they're really describing is chronic allergy of the airway. They often have childhood asthma. They have other atopic phenomena such as skin and conjunctival reactivity. And this is the allergic subset. Now, they may not have normal sinuses. There may be a small degree of sinus disease, and we're going to talk about how that appears. One of the markers, though, this is very important, of inhalant allergy is middle turbinate head edema. So when we look in the nose and see these polypoid-like changes coming off the turbinate, this is not nasal polyposis. This is a marker of inhalant allergy. And one of our PhD students, Anita Hammerson, many years ago, wrote a paper on the focal edematous change and polypoid edematous change that occurs in the turbinate head and said, how good a feature is this to predict someone's inhalant allergy status? So you can see down the diffuse and polypoid end. If you have a look at the numbers here, if you have diffuse or polypoid edema of your middle turbinate head, it is a very, very strong positive predictive value of having inhalant allergy. It's not a super sensitive, but a very strong positive predictive value. Now, it's important because we see patients like this. This patient here has giant polypoid edema coming off their turbinate head and may look like someone with nasal polyposis, but in fact, it's simply just polypoid edema off the turbinate. Some of these patients even present. This patient was sent to me, grade 3 polyps. As you can see, there's a polyp in the front of the nose, but the sinuses are completely normal. This is an inhalant allergy phenomenon. Now, if you believe that, then you'll understand this concept. So John Delgado is a very bright guy, and he wrote about the concept of what we call central compartment atopic disease. This is where inhalant allergy changes of the turbinate and septum create this pattern of disease where everything's centrally thickened and maybe just a bit of mucus trapping in the sinuses or peripherally spared altogether. He coined this disease because he really saw it as being just this extension of all the polypoid change in allergic disease. We went on to try to, with John Delgado and his team, to show if we could support some data to this. So we looked at 106 patients who had allergy and sinus disease, and we said, let's phenotype the pattern of disease, whether the frontal sinus here, an example, is completely normal, whether it has roof and lateral sparing, whether it was diffusely thickened or completely opacified. And we said, let's break these patients up into non-atopic and allergically sensitized patients. No surprises here. The allergics were maybe slightly younger and otherwise very similar in the groups, as you might expect. And what we did then is we said, what is the pattern of disease? Can we predict a pattern in that allergically sensitized group? We went through several different phenotypes, and not surprisingly, John Delgado's original description, this concept of laterally and superiorly spared sinuses, what we call phenotype B1, was the one that correlated best with allergic disease. And I love this thing here. That, you know, you might say that, Richard, it's only 70% versus 45%, but if you think of the number of confounders here, the fact that you can predict someone's allergy status just looking at the pattern of mucosal thickening on a CT scan is, I think, is astounding. So very convinced here. Now, but you should never be convinced just by one group. You know, I've obviously bought into John Delgado's concept here of central compartment atopic disease. But Ed McCool is a gentleman who is a rhinologist who works in the South. he had seen similar pattern of disease in allergically sensitized patients in the south of the US. And he wrote this concept of middle turbinate polyposis, essentially this middle turbinate edema, and compared it to typical sinonasal polyps. And so here we are, example of typical sinonasal polyps from his paper, middle turbinate head edema, exactly what we're talking about. And what he showed here was that those patients who had middle turbinate head polypoid change, middle turbinate edematous change, were likely to be younger. They were more likely to have allergic rhinitis, as you would expect, amazingly high, 83%, and less likely to have severe eosinophilic disease like aspirin-exacerbated disease. So typically, your pattern of someone who has inhalant allergy. Likewise, not surprisingly, that the nose score and Lund-Mackay score is much less burden of disease in the simple turbinate edema polypoid change group compared to those people who have true diffuse polyposis. And so here's a great example of an external study that validates the same concepts that we're describing here in this patient group. So here's one of the scans that was sent to me by my colleague Rita Sansoni, who's an ex-fellow, a 19-year-old girl with childhood asthma sent to him with sinus disease. And you can clearly see here now that he said, what a great case of central compartment disease. This girl's problem is not sinus disease. She may get some barotrauma when she flies, but her primary problem here is inhalant allergy. Now, just when we think we're clever doctors, I read through one of Valerie Lund's old books and found that, we really have to give credit to her. Amongst all the things that she did, she actually wrote about this in a book called Investigative Rhinology, and she called it the black halo sign. So amongst all the achievements that Valerie has done for our profession, here she is, a little gem in one of her books where she actually described this condition, a decade or more ago. And we've just recently put some data to it. Let's move on and talk about the second one here. This is the group in which don't have any airway problems until they're in their 30s to 50s and all of a sudden develop asthma and nasal polyposis. Or they get a viral event, and ever since the virus, they've had asthma and polyposis. And if there is a story here of someone who has an allergy, they often say, I was allergic when I was younger, and then I was well during my 20s and 30s, and then my allergy returned. And of course, that's not really their allergy returning. They've just simply developed an inflammatory airway disease in the setting of someone who had allergy when they were younger. Now, this is classic sinonasal polyposis and asthma. It's classically eosinophilic. And we know that it's an epithelial-driven process where local innate lymphoid cells are patchily distributed through the sinus mucosa and are activated. And that's why the condition is often patchy when we go in there and see it. So this is your eosinophilic CRS group. Now, they look very different in my opinion. These patients have a diffuse change. And when you look up at the middle meatus, you can see this typical polypoid edema, secretions. This is someone whose inflammatory disease is very severe. They have a lot of symptoms, even though you might call this only a grade 1 or 2 polyp. When we diagnose this condition, we use tissue. So when we take them to surgery and we do a sample, we use this structured histopathology report. It's freely available. It's designed to be used of H&E stains by routine pathology, and it just helps you clarify some of the simple aspects of sinus disease, most of which has very good research now on clinical outcomes. And one thing here we're looking for is this concept of eosinophil activation. So we look at the tissue density of eosinophils in some very simple groupings. We look at the degree of eosinophilic use and in evidence of eosinophil activation with Charcot-Leyden crystals. People say, well, do I have to take tissue? Well, you can use a serum eosinophil as a biomarker. So when the serum eosinophil is high, at least as high as that or 0.3 or more, the positive predictive value is good. But if your serum eosinophils are not raised, then it's not a very good negative predictive value. And so that's perhaps the one problem here is when it's positive, it's good, and you have high serum eosinophils, but it's not something when it's within normal range, it's hard to exclude tissue eosinophilia. Importantly here in these patients who have significant tissue eosinophilia is their serum IgE, so a classic marker of simple inhalant allergy, doesn't predict their tissue eosinophilia. And I think this underlies the fact that this condition is not an inhalant allergy-driven problem. This is an eosinophilic inflammatory airway condition that comes on as adults. Its origins are not a simple IgE-mediated disease. Now, these patients have a very different problem. One of the problems with these patients, despite being given simple nasal sprays, that nasal spray does not go to where it's required. The disease is up here, back here, up in the frontal, even back in the sphenoid. And these patients need to get anti-inflammatory treatment into these areas. Now, there's a lot of information now about the impact of how you deliver topical therapy into the sinuses and whether or not you've surgically changed the anatomy as to how effective topical therapy gets into the paranasal sinuses. Where does our anti-inflammatory need to be? It doesn't need to be in here. This is where hay fever and rhinitis exist. These patients have severe inflammation throughout their sinuses in this zone here. And these patients will tell you when they take oral steroid, it's amazing. Their smell comes back, they do great. And that's because we're delivering the medicine into their sinuses systemically through their bloodstream. But of course, when we do that, we send as much to the big toe, the liver, the bones as well. There's a lot of systemic exposure. And so the other way of delivering it in there is to do it locally. And to do it locally, you really have to create a simple sinus cavity for them and then give them some form of high volume irrigation with medication in it to deliver that local corticosteroid. Simple sprays simply do not get there. Now, we know this to be true from studies about where sprays go, but until recently, there wasn't a good randomized trial to really answer this question. Does how we deliver it impact the outcomes in real patients in real life? And together with Ray Sachs, we published this last year, this randomized trial that we ran over a number of years, demonstrating that corticosteroid irrigation supplied after a wide sinus cavity creation was much more effective than simple sprays in a randomized placebo-controlled fashion. So this was a study that we couldn't get funding from industry. It was investigator-initiated. There's no patents here. It's just simply reformulating an already out-of-patent drug in the sinus cavity. And we took patients who had CRS. They were diffuse disease, so not focal problems. They failed therapy. They were adults, and they didn't have systemic conditions. And we all did a style of surgery where it was designed to create a simple cavity or neo-sinus or full house vest. We gave them corticosteroids for a standard period and antibiotics only if they had a positive culture. Now, the intervention here then was that these patients added a medicine to their irrigation bottle and then used a nasal spray afterwards. So all patients performed a once daily nasal irrigation followed by a spray, and there was an active agent of mometasone, which was white base, odorless, and a placebo that looked exactly the same, but they didn't know which they were getting. So in the nasal irrigation, they either got mometasone or placebo, and in the spray, they either got mometasone or the placebo, but not both. And so we had two groups here, a placebo irrigation mometasone spray, a mometasone irrigation and placebo spray. This is how the bottles looked, completely controlled and placeboed both to ourselves and the patients themselves. Now, we did questionnaires, endoscopy, and a cone beam CT scan. Our primary outcome here was a VAS, a SNOT-22, and a global function score, and secondary outcomes were radiology and endoscopy score. We had 44 patients in this trial. Here's the flow chart of how they broke up. The dropouts were very similar between both groups. And recruitment was over a couple of years and was only closed out in December of 2015 and was a year-long follow-up, so it only finished at the beginning of 2017. This is the breakdown at baseline. So there were 23 in the mometasone spray and 21 in the mometasone irrigation, and they were very, very similar at baseline in terms of baseline demographics. Maybe there was slightly more aspirin-exacerbated disease in the active irrigation group, but didn't reach quite significance. Let's have a look at their disease burden. So at baseline, their disease burden was very similar as well. There's really no difference between the symptoms or on radiology of their disease burden. Now, this is what's important then. How they did overall. Now, very important. Operating on patients, giving them a saline irrigation and a steroid spray actually brings about a benefit for all. So it's not as if what we suspected to be the inferior arm provides no treatment. They all do well from this type of intervention. But the question is, does the irrigation group do better? And so what we can see here is a dramatic difference in nasal blockage VAS and a dramatic difference in endoscopy and radiology scores between baseline at 12 months. this is one of the best graphs here because the mometazone irrigation group are those in the yellow, and they were all doing better at 12 months. But importantly, those in the spray group, there were quite a number of patients who were beginning to fail at 12 months. And I think this represents people with active disease that's simply not being treated by simple sprays because the sprays aren't getting into the actual sinus cavity. And therefore, it's not surprising when you look at the 12-month follow-up here that the two groups break very significantly in several scores and overall VAS between the active irrigation and spray group, despite being similar at baseline. Now, the endoscopy score, this was only at 12 months because we only scored the open cavity. Mometazone irrigation had a much lower volume of disease, demonstrating better control of disease, and there was a much greater reduction in inflammatory burden when it came to the mometazone irrigation group on CT score. And so here's an example of a patient who was in the trial and they were on the active agent, and this is what their cavity looks like post-surgery. Now, you might take this and think that, okay, so you need to do surgery to control all CRS who have eosinophilic disease. That's not true. We do see mild patients, just like if people have mild asthma. Maybe they just need to wash a bit of mucus out of their nose. They hardly need any treatment. Then there's going to be the odd person who gets a bit of nasal congestion, occasionally with viral events, flares up, just like some asthmatics don't need to treat their asthma unless they get a viral event. And then this is when they present to ENT surgeons. You know, they really have significant burden of disease and they need to take systemic treatment to either treat flares or reduce the overall burden of their inflammation. And you can probably do that 2 to 3 weeks at a time for 2 to 3 times a year before you enter a zone of significant systemic absorption. If you do that year in, year out, you're probably putting patients at risk of side effects from corticosteroid use. And at that point, that's when I talk to patients about doing surgery, where the goal here is shifting them from reliance on systemic or tablet medicine to a regular local treatment to control their condition. Now, let's go in the last few minutes to talk about this last group. This last group is here. This is this non-eosinophilic patient. These are patients who don't seem to respond to corticosteroids very well. They're slightly older often, but they may not look so different. So here's a patient who was sent to me who's female, over 50, polyp change. You might say that the mucus looks a bit creamy rather than typically eosinophilic. And I said to her, you know, no problems. I know what we'll do. We'll redo your surgery and put you on a steroid irrigation. And this is what she looks like at 3 months. Really, absolutely no difference. And I should have known because beforehand, you know, she fits some of these criteria that have been seen in this non-eosinophilic low airway equivalent. Slightly overweight, no polyps, low IgE, corticosteroid insensitive. These are some of the things that have been promoted maybe as picking out this phenotype. But we can be more scientific because we actually have that tissue sample, that biopsy that we spoke about before. And this is actually this lady's biopsy. Now, if you can see, the summary diagnosis here was allergic/inflammatory polyps. But actually, if you have a look up here, she's got less than 10 eosinophils in her field, and she's got quite focal neutrophilic infiltrate. These are neutrophils sitting in the epithelium here. And so she's someone who really doesn't have eosinophilic disease. And this is the patient that we put on macrolides. The macrolides have a real role in managing airway inflammation, but it's just that they're not good for eosinophilic disease. And so here she is now, 3 months after macrolide. It's less than a subtle response. It's a complete response. And this is what I think we see in macrolide responders. And her lower airway, which was traditionally poorly controlled with inhaled therapies, got better as well. So the question remains, which patients will respond to macrolide immunomodulation? So we did a little study here. This is Gretchen Oakley, who works in Utah. She looked at macrolide responders, people who had this dramatic response that you can see here. And we said, what was different about them? Not many patients here. It's not a big group that we put on macrolides. But the macrolide responders were here on the left-hand side, and those who didn't respond to macrolides on the right. The SNOT22 here is slightly higher in the macrolide response. That may be more severe disease. And the features here that was significant is the macrolide responders were less likely to have a raised serum eosinophil, much less likely to show any form of tissue eosinophil infiltrate, and they were less likely to have established squamous metaplasia. So squamous metaplasia, where you lose your cilia and then I think you have a non-functional cavity, is really a whole topic for another talk. but these things hadn't set in the macrolide responder group. So my summary there is macrolide responders have low serum eosinophil, low tissue eosinophilia, and they have absence of remodeling, such as squamous metaplasia. No, so to summarize here, for the inflammatory patient, we still create a simple sinus cavity. It's not a plumbing or ventilation problem. There's many things that doing this allows. It allows for topical therapy, overcomes mucostasis, overcomes obstructive phenomena such as barotrauma, pressure, and it does probably reduce overall inflammatory load. But then I think of Sally Wenzel's diagram, and I make a real attempt to say, what am I doing now? Now that I've created and overcome some of the mechanical issues that come about from having inflammation in the airway, how am I going to treat the mucosa here? I really put the patients into these three groups, acknowledging that those in early life likely have allergic disease. This is where we push maybe simple nasal sprays is all that required because you're treating allergy. Immunotherapy we introduce early on. And other biologics such as omalizumab, which is an anti-IgE, probably have a role here. Now, but when it comes to that adult onset nasal polyposis asthma patient, these are patients in which we do push corticosteroid treatment hard. We want to make sure we deliver it in the lowest risk way, so we create a cavity and give the tumors an irrigation. I had some patients traditionally we used to be on low corticosteroid treatment systemically. In addition to that, patients who pick themselves out for needing systemic treatment often do so because their lungs aren't controlled with inhaled therapies either. But most of those patients in recent years have transitioned into biologics such as mepolizumab. And then finally here, we go looking for the patient who really looks like they're corticosteroid non-responsive and lacks tissue eosinophilia. And this is your macrolide responder. And this is where we try to apply a low-dose macrolide, really looking for a dramatic response within the first 90 days on treatment if you've picked it right. And so I want to leave us today on that talk really demonstrating how we go about at a tertiary rhinology center of breaking down our CRS patients and directing their treatments post-surgery to make sure we achieve the best outcomes and not using fancy laboratory biomarkers, but phenotype characteristics that are available now that we can use to help delineate how we should proceed with treatment. Thanks very much.
So thanks very much, Richard. Thank you very much for a great presentation, and to Claire as well. Just for the audience, in the bottom right-hand corner, there is a space for writing questions, and if you do have any questions, please write them down, and Agnieszka and I will get them to our panelists to talk about. So I'm going to ask our panelists a few questions, and my first question is really aimed at Richard, because there are many surgeons who might think that creating a near-sinus cavity is only for those with very severe disease. How do you go about selecting patients to undergo this type of complete surgery?
Ray, that's a good question. I get asked that a lot. I think the concept of somehow doing more or doing a type of surgery just because the patient seems to have severe disease or has symptoms or complains a lot really has no basis in science or the pathophysiology. The idea when I was a trainee that someone complained enough when they just got a bigger whack of surgery. And I think that we've moved beyond that. And what we try to do now is really match up what we're doing surgically with what we're trying to achieve in these patients. So in patients who present with patchy or diffuse disease, it doesn't matter how severe or mild they are, if you make the decision that they come to surgery, in my opinion, it's one where then you should do a type of surgery that sets them up to control that disease or pathophysiology that's occurring. Now, one of the traps here then, I think, for people who are used to doing very limited polypectomy or very limited surgery is that they only reserve a proper operation, in my opinion, for the most severe patient who's had 10 previous minor procedures, whose asthma is not well controlled with inhaled treatments, and then their one experience of actually doing something that I think fits the disease is in the person who is so severe that they're probably someone who is going to fail local treatment, just as their lower airways may be failing already. So my feeling is that people should really try to marry up the surgical condition the surgical treatment, I should say, and the disease condition very early on. And I think some of Claire's data showing that, people who are managed effectively early on in the course of their disease are probably going to do better long term. And I think we see that, down the track.
Thanks very much for that, Rich. A great answer to a difficult question. Claire, my first question to you is, there were two words that you used repeatedly when you were talking about the importance of the clinical presentation when you were defining between CRS with polyposis and without polyposis, and that was most likely. You kept saying that they were most likely to have this or most likely to have that. Now that you've seen Richard's presentation on histological endotyping, how valid do you really think that the phenotypes are in terms of this old-style classification of CRS with and without polyposis?
I'm trying to give people some tools to be able to make that decision in the clinic at the first visit before they get to surgery and they have the opportunity to take that histology. This is a leader in to get the medical treatment right, and I agree absolutely that the work on the histology replaces that when that becomes available. But we're trying to get people in the right group at the earliest possible opportunity. And just those simple features that you've shown with the middle turbinate edema, I think is a really valuable way at the first visit to point the patient in the better direction. So we want as many of these tools as possible, and certainly when biomarkers and histology and everything else becomes a routine part of practice, that will supersede phenotypes and the guesswork that we use to some extent.
Thank you for that, because I actually agree completely with you. And I think that the whole concept of just classifying CRS into with and without polyposis is really outdated and is a poor classification. My feeling is that based on a lot of the research that we've done, we've shown such a high degree of eosinophilia in CRS without polyposis and patients with neutrophilia in CRS with polyposis that it really makes it quite redundant in terms of our long-term management. And Rich, on the basis of what you've shown with eosinophils in both CRS with and without polyposis, how do you actually determine which patients you're going to manage, for example, with steroid, etc., prior to you obtaining your histological specimen? Not all of them are going to arrive with histology. In fact, none of them until you operate on them.
I think Claire brings up a really good point in the fact that we use the phenotype of polyp, non-polyp, traditionally, but we aren't really promoting other aspects of the condition. One thing that I think is enormous value are people who have lower airway involvement. So the minute they have lower airway symptoms of any sort, it goes to show that they really are an inflammatory sufferer, almost for sure. They've got a diffuse process across the entire airway. The next thing I look at is people who have corticosteroid sensitivity. So we all know these patients, they touch prednisone and they love it. They think within a couple of days it's magic, the smell's back. And I think that's a great sign of a predictor of being eosinophilia. I would actually portend that response to systemic corticosteroid is a stronger indicator of having eosinophilia than polyps, non-polyps, in my opinion. And I think they're the sort of things that we need to promote. And very unfortunately, as a profession, we're struggling at the moment to move beyond polyps, non-polyps. And I'm hoping with EPOS 2020 and some of the new guidelines that maybe we can actually move away from this. There won't be consensus, though. There'll be people wanting to hold on to the old ideas. But I really think we need to move on. It doesn't have to be perfect, but we have to break the shackles of polyps, non-polyps, I think, to move forward. Because I think unless we provide a framework for clinicians to use something beyond polyps, non-polyps, then I think we're going to be locked in this situation where we can't make progress.
Excellent. Now, Claire, just before we start signing off, we've got another few minutes to go. How do you approach your patient with polyposis from a medical point of view? I know how Richard approaches from a surgical point of view, but from a medical point of view, when you start off, what is your approach the first time you see the patient in your clinic?
So the vast majority of patients that I see will have usually quite large polyps to have got through the system to ENT. And my approach is to use maximum medical therapy at that first point of contact. first point of contact. A lot of these patients will have been given an inadequate dose of topical steroids by their GP. They'll have been told they can only take it for a week, 2 weeks. They won't have even collected the prescription, as I mentioned. And what I really want to do is see, as Richard mentioned, how well they respond to a course of corticosteroids and the duration of benefit. And that really gives me a guide as to whether this is someone that's going to benefit from going to surgery or whether they are going to do well with medical therapy. So that first visit, I will give them steroids, 0.5 milligram per kilogram for up to 2 weeks. And I will also repeat that sort of up to 3 times a year reasonably comfortably. I give them topical steroid drops in the UK in the form of corticosteroid nasals. And I combine that with doxycycline, 100 milligrams once a day for 3 weeks. And I want to see them at about 4 weeks after the start of treatment to see how well they've responded. And some people won't get any benefit at all, and I guess they're going to be the non-eosinophilic patients. Some people will feel fantastically well for the first week of steroids, but the minute the oral steroids stop, their symptoms will start to recur very quickly. And then the patients I'm going to be thinking about taking to surgery. And some patients will do well and will still be maintained, and at that point I step them down to a maintenance course of topical steroid drops and corticosteroid nasals. And I ask them to let me know when their sense of smell starts to deteriorate. And that's the really early sign that they're starting to fail. And I use that interval of benefit to really then plan my ongoing treatment and at what point, if at all, they'll need surgery.
Can I add to that, Ray?
Yep.
You know, I think that's very similar. You know, I talked about my 3 groups. Well, the allergic sufferers, I think, are relatively easy to pick out. You know, they're young, they have childhood asthma, IgE-driven disease, and they often have these classic scans that, as John Delgadio Valerie Lund has described, the black halo sign. I don't do surgery for them early on, but they almost always buy surgery because they have edema and sinus blockage, and they get barotrauma and some secondary sinus dysfunction. So many of them need sinus surgery, but the biggest issue for them is much of their nasal symptoms are not driven by their sinus dysfunction. It's driven by their inhalant allergy. And so almost all those patients in my hands, in my clinic, go on to immunotherapy. And we promote immunotherapy, and I delay the sinus surgery 6 or 12 months into immunotherapy. And at that time, I think they do incredibly well. What I see often is patients who look like this and have had surgery elsewhere, and they come and see me, and their sinuses are perfect. When you look in, they've got a perfect-looking sinus cavity, and they're a patient bitterly complaining of symptoms. And it's often to the befuddlement of the previous ENT surgeon of why they're not right. Well, the reality is that's their inhalant allergy, which is driving much of their nasal symptom burden. So that's the reason why I introduce immunotherapy early in that group. When it comes to eosinophilia, when adult patients develop asthma and polyposis, I really use that concept of the number of courses of systemic treatment a year. When it hits about 2 or 3, with either, as Claire said, very limited benefit after the systemic therapy is finished, or they need multiple courses to keep them good, that's when I transition them to a type of sinus surgery to set them up for local treatment. But there's no point taking them there if they're not prepared to do a local corticosteroid irrigation. That's like giving a patient an asthma inhaler and they're outright not going to use the inhaler. There's sort of no point, in my opinion, going that direction. They'll just recur very quickly. So I try to have patients buy in. And the way to have patients buy in is not to give them a whole lot of corticosteroid irrigations without surgery, with grade 2 or 3 polyps in their nose. This does not work as a treatment, but I've seen this pattern starting to appear in our profession. And then finally, I take probably the non-eosinophilic patients very early to surgery because it really is someone I'm suspicious of. They're older, they're perhaps female, they're a little bit overweight, and they have non-corticosteroid responsive disease. And I'm sort of on the lookout for non-eosinophilic disease and there being a macrolide candidate. And unlike the example I gave, I try not to let the patient fail at 3 months and then start my effective treatment. I try to pick them up early, and I review the pathology at 2 or 3 weeks when they first come back from their surgery, and I start the macrolide then if I've got the direction to do so.
Thank you very much. One last question before we wrap up. Claire, what would you say to the audience is the most valuable tool for assessing patient response? Do you use a SNOT-22? Do you use a Kennedy endoscopy score, or are you utilizing any of these newer generation technological apps on your phone where patients self-document?
I think it's got to be a combination of symptoms and endoscopy score, and I think you learn a lot from both, because we see some patients who, endoscopy still looks dreadful but have dramatic improvement in symptoms, so the benefit is going to be maintained. So I think, ideally in combination, but the apps and the online scores do allow you to monitor patients remotely, which is of value with a common condition.
Excellent. There's no questions from the audience. So I'm going to ask other representatives if there's anything else that they wish to comment on. Otherwise, I'm going to draw this webinar to a close. Rich?
No, it's good, and I thank Agnieszka and the Medtronic team for putting it on, and hopefully this maybe is a webinar in the first of a series. For those who've maybe missed part of this, I believe it'll be available again in archive form, so look out for it.
Thank you, Richard. Claire, any last comments?
No, just thank you very much, Agnieszka, for setting this all up, and active moderation very great.
Excellent. Agnieszka, I'm going to hand back to you now.
Thank you very, very, very much. All we can say from the medical perspective that the knowledge, understanding of who we are dealing with is critical for the good clinical outcome of our patients. So thank you again for spending the time with us. Thank you for accepting the invitation. And yes, definitely we're looking for the future and another educational event we can run together. Thank you so much, and have a great day and have a good night. Thank you.